outline. So, what is a peripheral neuropathy? Well, it's pathology of the peripheral nerve. Important point to remember here is it's not just the peripheral, what we term the peripheral nerves. It includes the cranial nerves as well. So peripheral neuropathy can also affect particularly cranial nerves 3 to 12. Okay. It should be compared, however, to a radiculopathy and a plexopathy. So a radiculopathy is the term used for the roots, when there's a pathology in the roots from the spinal cord of the nerves. While a plexopathy is a pathology of the plexus, so the brachial plexus. So, very broadly, you get mononeuropathies and you get polyneuropathies. Mono, obviously, one, poly, lots. However, you can also get a rather paradoxical thing called mononeuropathy multiplex, where you get lots and lots of single nerve lesions. So lots and lots of mononeuropathies is mononeuropathy multiplex. That's just a very basic overview of the different types. I think in your notes, there's a kind of table of the different mechanisms of injury. And actually, it's quite useful to know some of these mechanisms because it kind of reminds you of some of the most important causes if you learn the ones that go along. So demyelination is one of the absolutely key processes that goes on in peripheral neuropathies. And obviously, the myelin's removed, and this affects the conduction. So the conduction along the different fibers will be severely reduced because of the loss of myelin. And two important conditions to be aware of are Guillain-Barré syndrome, which is the post-infective demyelinating polyneuropathy. So if you see in an EMQ someone who has say a gastroenteritis or a viral infection a couple of weeks preceding, then suddenly develops a peripheral neuropathy, think of this, Guillain-Barré, post-infective. The other is a group of hereditary neuropathies called the hereditary motory sensory neuropathies. But don't worry too much about those, just remember GB syndrome. In terms of the axons themselves, there are various things that cause direct damage to these. And the ones that you should remember here are the toxic neuropathies. So alcohol being very, very important, but also some particular drugs, which I'll talk about in a bit, and some certain toxins, particularly lead. So lead is the most important toxin causing peripheral neuropathy. You get other things as well. So focal compression, if the nerve's compressed, doesn't work as well. And these are all the entrapment neuropathies, which I'll go through in a minute. Next, infarction. So if there's a problem with the blood supply to the nerve, and the blood supply to all nerves is supplied by something called the vasa nervorum, then the nerve stops working. And the most important condition here is diabetes. One of the microvascular complications of diabetes is peripheral neuropathy. And then finally, infiltration. And in this, rather like what Rashmi was talking about with giant cell arteritis, the actual nerve gets infiltrated with inflammatory cells, and that leads to breakdown of the nerve. And the two common causes here are granulomas, so that's both in both sarcoid and TB, any of the diseases associated with granulomas, and then finally malignancy as well. Okay, so I just want to go through some very basic and very common mono and polyneuropathies. So, mononeuropathies tend to affect nerves that are anatomically exposed. That's a key principle. And the entrapment mechanism that I spoke about a second ago is the most important thing here. The features that you get with each mononeuropathy depend on the specific nerve, obviously, that is compressed. But you need to think about the features both in terms of motor features and sensory features. And therefore, I'll try and do that with the following ones. So the most important one, and the one you'll probably see most commonly, is carpal tunnel syndrome. The key nerve here is the median nerve. The median nerve gets compressed at the wrist because where the transverse carpal ligament at the junction between the wrist and the hand traverses across the wrist. This is a site where often, in association with inflammation, obesity, all these kind of things, you can get entrapment. It's a narrow space. Most causes are idiopathic. However, there are a few important ones, important other causes to be aware of: hypothyroidism, acromegaly, pregnancy, and obesity. Now, patients will describe tingling and paresthesia, which is fairly common for any neuropathy, mononeuropathy or polyneuropathy. Just a particular slide with exactly the distribution of sensory loss that they get. And this is really important that you remember. They get loss of the first 3, half of the 4th digit. Okay? In terms of the motor features, the median nerve, the most important muscles that it provides are those of the thenar eminence. So they get weakness of thumb abduction. Those are the 2 important. There are also some very specific tests that you'll often see mentioned. And both of these tests, you do them on the patient with carpal tunnel, and this tends to provoke their symptoms. So if they have paresthesia and tingling, if you actually tap on the carpal tunnel itself, they get the symptoms. And this is called Tinel's test. The other one is where you hyperflex the wrist and get them to hold it like this. And then that will bring on the symptoms as well. That's called Phelan's test. Okay. The other ones, common peroneal nerve palsy. This is very common, but it affects the common peroneal nerve just below the knee. And usually it's actually not in association with a fracture, like shown here. You can get it with fractures, but usually it's because of compression at that site. So typically, say, someone who's broken their ankle, they have to have a high cast on for a number of weeks. They can get compression of the nerve at that point, leading to a common peroneal nerve palsy, which may indeed not manifest itself until the cast has come off. And others with prolonged pressure, immobility as well. And importantly here, it's called the you get anterior compartment symptoms. Okay, so most importantly, it's foot drop. So that's your motor thing. Remember, foot drop. And then sensory, I don't know what's happened here, but you get loss of sensation over the dorsum of the foot and particularly the lateral border of the foot. Foot drop and loss of sensation, lateral border. Okay, I know that in one of the tables it talks about Bell's palsy. It's a bit of a stupid place for me to have put that. I'm going to talk about that a bit later. But I want to just talk about some really common other ones, specifically for your exams. Okay, the other 2 nerves in the upper limb that you'll commonly get asked about is this. Anyone know what this is?
Radial nerve.
Yeah, that's a radial nerve palsy. Yeah, okay. It causes wrist drop. And the 2 situations in which you get a radial nerve palsy is in something called Saturday night palsy, which is usually drunk people who fall asleep with their arms over the sides of chairs. It causes a compression on the upper arm, compresses the nerve, causes wrist drop. The other situation is in a fracture, so a mid-shaft fracture of the humerus. Those are the 2 important ones. This one, anyone? Ulnar nerve. This is an ulnar nerve palsy. Okay? And this is what's called a claw hand. Ulnar nerve is most commonly injured at the elbow. Any pathology, any fracture at the elbow, you ever see that with a neuropathy, it's the ulnar nerve, okay? And it causes claw hand. Okay, quickly, mononeuritis multiplex. In mononeuritis multiplex, the definition is that there's greater than or equal to 2 single nerve lesions. And those lesions may occur at the same time, or they may occur one after another. Now, the important thing here is it's not due to entrapment like the other neuropathies. Usually there's some systemic cause for this. And once again, any nerve can be affected, a peripheral nerve or a cranial nerve. This is the way you remember the causes of mononeuritis multiplex. Okay, Ward's PLC, one of the most famous mnemonics. Okay, Wegener's amyloid, rheumatoid, diabetes, you can read. Okay, but just remember and try and remember these specific causes. Okay, finally, polyneuropathy. What is polyneuropathy? Basically, you've got a pathology of multiple nerves, and it's usually symmetrical. Once again, you should split the features into primarily motor and sensory. Now, if you remember back to last session, I talked about the most common causes of upper versus lower motor neuron lesions. Remember, peripheral neuropathies, one of your important causes of lower motor neuron patterns of weakness. In terms of the sensory aspect, and this often presents before the motor aspect, the important things are once again paresthesia. And this typically occurs in what we call a glove and stocking distribution. This is what a glove and stocking distribution is. Often in real life, it doesn't work as nicely as this. You don't just find that they have this precise level where they suddenly get sensation back. You can sometimes get patchy loss, both in the arms and the legs. But this is the characteristic thing. So when you guys are testing for your dermatomes, I hope that you've been taught to kind of do it by dermatomes, your sensation. Do them in the upper limb down like this. Okay? If you find distally, say you're doing testing C7 in the upper limb and the middle finger, if you find sensory loss there, what you should then do is test for glove and stocking sensory loss. And what you do is you start distally and you work proximally, asking them when they feel it or when they feel some change in the sensation to you touching. And that shows usually quite nicely one of these glove and stocking neuropathies. Now, there's lots of different sieves. Now, Junaid likes Vindicate. I like this one, Vintamedic. Some other people like Tin Can, MD, or something like that. Doesn't matter. The important thing is to have some sort of system and to know some common causes for peripheral neuropathies. And this is the one that I like to use. So, vasculitis. Any vasculitis can affect the blood supply to the nerves. Infection, particularly HIV. HIV infection, both because of the infection itself and also because of the treatments that we use to control the infection, can cause peripheral neuropathies. Neoplasia, particularly myeloma, is associated with peripheral neuropathy. And you should also remember that not all carcinoma neuropathies are because the actual nerve has been infiltrated by a tumor. There's a system called paraneoplastic syndrome, which if any of you watch House, you'll all be familiar with. It's the syndrome that just causes random things, and there's a tumor in the posterior fossa that's 1 millimeter and they get a foot drop or something. You know, it's just random. Okay, so paraneoplastic is your random features associated with malignancy. Trauma, well, not really, because remember, trauma usually causes the mononeuropathies. Autoimmune disease, we've spoken a little bit about Guillain-Barré, your post-infective polyneuropathy, and lupus, of course, the house enthusiast, can also cause it. Metabolic, diabetes mellitus, and renal failure. Renal failure, really common. So toxic uremias cause peripheral neuropathy. Electrolytic, no. Degenerative, no. Iatrogenic drugs, one of the important causes of axonal degeneration is specific drugs, and the ones you should know about are isoniazid, which is used in the treatment of TB, and phenytoin, the antiepileptic agent phenytoin. There's a list of about 20 of them, but don't worry, just learn the common ones. And then finally, this condition of congenital inflammatory demyelinating polyneuropathies. Yeah. In terms of treatment, as always, as Rashmi said, treat the cause. And then often pain can be a real issue for people with chronic peripheral neuropathies. They get something called neuropathic pain, which is incredibly difficult to control. And there are whole clinics or pain clinics out there where people try to get a grasp on this pain and try and control it. But essentially, the things you should know for neuropathic pain is that you don't just treat it with paracetamol and NSAIDs. You have to often use even tricyclic antidepressants, amitriptyline, and these drugs as well that have a more central effect on almost the perception of pain. Okay, so mononeuropathies, important single nerve lesions. Remember Ward's PLC. Polyneuropathies, remember that glove and stocking distribution, lower motor neuron pattern of weakness, and then have some way of breaking down the different causes and know a few of them.